And the panelists today are all going to speak about evidence-based interventions. We have people from the federal level, state level, community-based organization, and from research science. And we'll start with Charles Collins, who some of you may know. Charles is the section chief in the capacity building unit in the HIV division at the Centers for Disease Control. He has worked with a team of 11 behavioral scientists on disseminating and helping organizations to integrate effective interventions, and particularly the 25, that's so-called DEBIs, that are considered the most effective. And with no further ado, Charles is going to talk to you about that, and then we'll go on to Barry. Thanks.
Thank you very much. Well, thank you very much for having me here today, and I'm going to talk a little bit about the DEBI project, a CDC project that is in March had its 7th year in operation. And so let me just talk a little bit about some of the steps that we do in that process and some of the interventions. That's the part that I'm going to cover today. First of all, we really would like to make sure that when programs apply for funding, that they have a document that describes the intervention that stands as an agreement between the Centers for Disease Control and the funded agency that we fund. And so for each of the DEBI interventions, we develop a roughly 11 to 13 page summary of that intervention, which we post on the CDC website, and that's the procedural guidance for our interventions. Do you mind if I see if this will work for that? I'm going to do. Can you hear me just as well this way without the microphone? No, you can't. Okay. All right. So that's where we post our interventions, and any intervention that we indicate in a program announcement that we're going to fund, it will be included in the procedural guide. The second website, or the second point down there is this is our resource website. It's the DEBI website, and I'm going to talk a little bit about that at the very end of the presentation, but it is the method by which people register for training for various interventions. They can also download materials, and we're constantly putting new materials on that website so that people can have resources around behavioral interventions. Now, we use a 8-step model for disseminating interventions and sending them from the research community out into the practice community. So the first step of this is planning. We want to find out from communities what are the interventions that they need. And so we listen to community as to what are the interventions that they think would work in their community. And then we begin to try to match that to the publications that are coming out of the scientific community. The second step that we take in this process is that we plan with the researchers. When we begin to take an intervention and we begin to distribute it and move it out into community, we ask the researcher for their help in planning that process. In many cases, the researcher has already begun the diffusion process. They've already begun to distribute their materials that they've developed. We also talk to the 50 state AIDS directors around the United States. We ask them, we'll call the AIDS director of Mississippi, the AIDS director of Alaska. We'll say, what are the interventions that Alaska needs? What are the interventions that Mississippi needs? What are your training needs? So we go through and ask that. So we really look to try to develop a planning approach that includes multiple stages, including the researchers, communities, as well as the health departments around the country. Our next step is health marketing, and that is to begin to market the interventions to executive directors of CBOs and begin to market the interventions to program directors of community-based organizations. And to also ask them, what kind of materials do you need to help make a decision around this intervention? So many times people will say, well, I'd like to see a budget. Or if I'm going to have to hire 3 staff to work on this intervention, I'd like to see job descriptions. Or someone would say, well, if I'm going to do this intervention, I'd like a logic model. So we develop these materials and make them accessible so that communities can make decisions about interventions. We also developed a training course, which we're distributing around the United States, on how to select an evidence-based intervention for your target population that also meets the needs that your agency can implement. So it helps people think through, how do I meet the needs of my community in an intervention that my agency can actually implement? Policy incentives is our third step, and that is at the federal level to make sure that our program announcements indicate that we will support evidence-based interventions, that we will give grants out to evidence-based interventions. At this point, we spend $55 million a year that we give to community-based organizations to do evidence-based interventions. And this will continue. I will tell you that this will continue as a CDC strategy, that we will continue to support at roughly that level CBOs in the field who are doing evidence-based practice. The fourth step is package design. We consider the packages that we develop around these interventions to be living documents. You know, there's a philosophy, there's different philosophies about what is an intervention. And there is a more conservative philosophy that this intervention was developed and tested with a couple of agencies, and it has these core elements, and that everything has to be done exactly the way the research was done. And there's another, possibly more liberal approach to thinking about what is an intervention. And you have to think about that an intervention, as it passes from community to community, and people begin to think about what is the meaning of this innovation for my people? What does this innovation mean for my agency? This is more of the Debbie approach, so that when we hear about people working on the Debbie interventions, and they have lessons learned, we try to incorporate the lessons that they learn into our process. We try to capture products that are done. One of our interventions is an intervention called SISTA, for example, which was originally for African American women. Well, there's a community-based organization in Boston who their target population is Haitian women who are recent immigrants to the United States. So they took the SISTA intervention and they translated it into Creole, and they started developing art and other materials in that so that the intervention would be attractive to Haitian women. So, you know, I mean, as soon as we heard about this, we called up and said, we want that product. We would love to have that product because we understand there's a CBO in New Orleans that also works with Haitian immigrants, and we would like to make sure that they get that product that you translated up in Boston. So our approach to interventions is a very fluid approach in terms of working with community and dialogue, in terms of understanding how these interventions can be used in multiple settings with multiple populations with multiple resources and conditions. The fifth part of this is training. And that is that we do believe that you have to have more than just the package to do the intervention. We do believe that you need to go through a 3, 4, or 5-day training, depending on the complexity of the intervention, to learn how to actually implement what is in the package. We also have capacity building and technical assistance available. We're just about to fund a new family of of capacity building providers. We're going to be spending $32 million a year on capacity building to build the capacity of CBOs around the country and clinics and health departments to be able to sustain evidence-based practice. We do quality assurance, and that is there's a broad range of quality assurance aspects to this, but one aspect of this is we just want to make sure that we have good trainers who get up and teach the curricula and are able to get across the information to the people in the audience, and so this is one of our main quality assurance steps. Finally, evaluation. We have evaluation at multiple ranges, going all the way from looking at process evaluation and fidelity to the core activities of the intervention, all the way to looking at the outcomes that some of our community-based organizations are able to achieve. There are around 2,200 to 2,300 CBOs in the United States. And so our philosophy is not that we expect all 2,300 of these agencies to do really outcome evaluation or outcome monitoring. If you're doing evidence-based practice and you are doing the intervention as we have taught you to do, we are not that concerned with outcome monitoring. We like to do sentinel approaches to outcome monitoring. If you have 2,300 agencies doing evidence-based practice, you can go in and randomly select 10 that are doing SISTA, 10 that are doing healthy relationships, 10 that are doing partnership for health, and you can look and see what is the outcome variance that's happening in the field. And so this is the step we're at in terms of our evaluation processes and evolution. Well, let's talk about the interventions. So the first thing, those 8 steps was our dissemination model. And now I'm going to talk a little bit about some of the interventions that go through this dissemination model. Well, we have some interventions that really are designed to be adapted for all populations. The Community Promise is the one that's probably the most obvious of these. Community Promise is an intervention that's based on role model stories that show people moving through the stages of change towards new, healthier behaviors or leaving behind unhealthy behaviors. And so these role model stories can be written in any language. They can be written for any target behavior. They can be written to match the culture of any community. And so it's an intervention that can be used for multiple purposes to help people think through the process of moving through the stages of change towards more protective behavior. And then, of course, there's our Project Respect. This is our intervention that was originally tested along with as a pre-test, post-test model for behavior change, but it's a model that indicates if you use a client-centered approach with people around what are their behavioral goals that they wish to change, that you can help people change their risk behavior if it's in a supportive one-on-one type of client-centered approach. We have a range of interventions for men who have sex with men. The first of these is our popular opinion leader developed by Jeff Kelly. It's a social network approach to intervention. The most common misunderstanding when we communicate with community-based organizations about the popular opinion leader is they think that the popular opinion leaders are outreach workers. And that is not right. And so I'm just going to take a second to distinguish them. A popular opinion leader is a person identified in a social network who, through their communication and their relationships with their friends and their family and the people that they interact with, can persuade other people about some value, about some norm, about some behavior. Their influence is with people that they know. And they need to be volunteers. And they really should not be paid. They should do this as a natural, relaxed approach to working with their friends and associates. Outreach workers, on the other hand, are people that are usually employed, and you ask them to talk to strangers. You ask them to go into high-risk neighborhoods. You ask them to distribute condoms, brochures, do risk assessment. So we point out that the POL, the popular opinion leader, and the outreach worker are very different. And they may, in fact, complement each other, but they're very different approaches to doing HIV prevention in community. D-UP is our African American MSM adaptation of the popular opinion leader. We had an outbreak of HIV in North Carolina among African American MSM. We went in, the state of North Carolina said, what can we do about this? And the CDC recommended doing the popular opinion leader in the state of North Carolina using their historic black colleges in partnership with their community-based organizations. And what they did was they took the popular opinion leader and adapted it in terms of artwork, in terms of training sessions, etc., so that it was more appealing for young black gay men. And so we have a version of the popular opinion leader called D-UP that we're now diffusing around the country. The third of these is Many Men, Many Voices. It started out as an intervention that was an adaptation of Jeff Kelly's Aries study that he did back in 1989. However, it was culturally modified for black gay men. And we've done some testing recently. We just had a new publication on Many Men, Many Voices done as a weekend retreat so that people would leave, a bus would pick up 10, 12 gay men, black gay men on Friday and go do a weekend retreat, bring them back on Sunday evening, and they would get the full dose of the intervention at a state park or some other site where they could go through the whole intervention in a weekend. Empowerment is our intervention developed by Susan Kaglis. This intervention is an intervention, it's a multi-component intervention. Susan Kaglis is one of my heroes. She's so sensitive to working with the risk community and thinking about the design of interventions. She started talking to young gay men and saying, what would it take to get you to go to a community-based organization and get some prevention? And young gay men were saying, I wouldn't go there for anything. I wouldn't be caught dead in a CBO. I would never go to a CBO. So she said, well, what would you do then in terms of prevention? What would make you get involved in prevention? And they said, well, if I could find a way to meet other young gay men. And so, so she said, well, then let's develop an intervention that has that dynamic to it. So her intervention has got some nice features. One of the things about her intervention that I think is underestimated is the fact that her intervention is really in many ways a community building intervention. So it has some real strengths in that regard also. We have some interventions for women. These include the Real AIDS Prevention Project. It's an intervention that uses a range of activities, including role model stories, outreach workers, peer volunteers, and a one-time educational group for women. So it uses multiple strategies together in that intervention. We have the SISTA intervention developed by DeClemente and Wingood, an intervention for African American women that uses the theory of gender and power as one of the bases for the intervention. The intervention posits that men in our culture frequently have more sexual power than women. They make more decisions around whether the condom is used or whether the condom is not used. Well, if that's the case, how do we in fact help women with sexual negotiation skills so that they can begin to work with their male partner to get the male partner to use a condom? And so it's an intervention. And one of the things that DeClemente and Wingood found in their original formative research was when they started talking to women about how do you convince a man to use a condom, the fear was loss of femininity. So that women said, I want to be able to convince my male partner to use a condom, but I don't want to come across as aggressive. I want to remain feminine in that. So the intervention helps balance that process of how do you sexually negotiate and still have the woman feel that she is acting in a feminine manner to her male sex partner. The Willow intervention is also developed by DeClemente and Wingood, and it is for HIV-positive women. It has a cope and stressing component to that intervention. And then finally, our sister-to-sister intervention, I put it here on the list because we're beginning to diffuse it now. We're just starting. It's an intervention which was developed by Loretta Jamont. And Loretta Jamont is on the faculty of a nursing school. Her PhD is in nursing. And so she's very interested in what role nurses could play in terms of helping to change risk behavior. So she developed everybody in this room has gone to the doctor, and a nurse comes in, they take your temperature, they take your blood pressure, they say, why are you here to see the doctor? They all write it in the chart, and then they leave you for 15 minutes before the doctor comes back in the room, into the examination room. So what Loretta Jamont said, well, why don't we use that 15 minutes? Why don't we ask nurses to educate women who are coming in to see a physician, and let's use some of this time before the physician comes into the examination room to educate people about their risk and help them with protective behaviors. Now, we do have some Debbies for injecting drug users. We have Finn Rhodes' safety counts, It's an intervention that uses an outreach team and also a team that's within the agency. It involves social events for active drug users. It was found to work with both active injecting drug users and crack cocaine smokers. It is a harm reduction intervention in that each client gets to choose their own risk behavior. If a client comes in and says, I have 16 sex partners a month, and my goal is to move to 15. Or someone says, I'm injecting cocaine 7 days a week, and you know what? My goal is to at least not inject on Sundays. You know what? That is wonderful. In that intervention, it's a harm reduction philosophy, and people are encouraged, if they need to take small steps towards their behavior change. We have our first intervention, which was actually developed by a Spanish-speaking researcher. All of her staff spoke Spanish, and all of the clients in the study were Spanish. The intervention was developed in San Juan, Puerto Rico. It's by Dr. Rafaela Robles, and it's an intervention that uses a case management model with injecting drug users to help them also on a range of behaviors around risk reduction, around seeking treatment if that is a goal that they would like to be involved in. We also have the CLEAR intervention developed by Mary Jane Rothram Boris. It's for HIV positive young drug users. And so we developed this model, CLEAR, as a prevention case management model, so that people could go through the intervention and would be supported in behavior change one-on-one with their counselor. We have several for HIV positives. I've mentioned a couple of these before, so I can go through this slide pretty quickly. One of these is Healthy Relationships. It was developed by Seth Kaligman. For HIV positive men and women, it's a group level intervention that uses motion picture film clips to stimulate discussion around status disclosure, self-efficacy around status disclosure, and then moving on towards safer sex practices. There's also Partnership for Health, developed by Jean Richardson. It's an intervention that's delivered by the physician to the HIV positive patient with each and every clinic visit. It's meant to be a 4-minute intervention where the physician has 4 minutes of messaging to their patient with each visit. We have 2 for heterosexual adults. We have Voices, in which we have both an English and a Spanish version of Voices. Now, how many people have been trained in Voices or have ever seen the Voices films in the audience? Raise your hand. Okay, so a few of you have. The Voices intervention was developed by Lydia O'Donnell, but she developed the intervention about 12 years ago. And needless to say, people now look at the video and go, oh my God, people don't talk like that anymore. Or, they'll look at it and say, look at that hair on that lady, And so what we've done is we've gone in and we've taken and redone the intervention. And so we now have a new Voices package that has updated DVDs. We're moving from video to DVD. And so we now have the DVDs for the new Voices intervention. Now, just to give you an idea about how many people are using the interventions across the country, we announced that for the Voices intervention that we had these new DVDs. And if any CBO was doing Voices, let us know on our website, and we would send you the new Voices materials. We had 450 CBOs tell us that they were doing the Voices intervention and asking us for the new materials. We also have Connect. Connect was developed by Susan Whitty and Nabil El-Basel at Columbia University. It's an intervention that works with heterosexual couples, Latino couples, and African American couples. So we're working now to begin to diffuse that intervention. Our ones for youth include Street Smart by Rothram Boris for homeless and runaway youth. We have an intervention here by Bonnie Stanton called Focus on Youth, which works with African American young people who are in the 7th, 8th, and 9th grade. And there's an impact video, and the impact video goes to their parents. So you're working with the youth, and then you're also working with the parents in Bonnie Stanton's intervention. And then finally, DeClementi and Wingood's Shilay intervention. It is for young, sexually active females between the ages of 14 and 18. It is not meant to be an intervention for virgins. It's meant to be an intervention for women who are young women, very young women who are sexually active. DeClementi and Wingood, when they began doing their formative work and focus groups, and they started interviewing young women who were 14, 15, and 16 who were having sex, one of the questions was, well, how old is your boyfriend? What they found frequently was that the boyfriend was 10 years older. So that the girl was 15, she's in the 9th grade, she has a boyfriend who's 25, who has a job, who has a car. So in many ways, he has so much more power than she has. Power in terms of money, power in terms of status, power because we give males more power. So how do you work with a 15-year-old 9th grader so that she's able to negotiate with a 25-year-old boyfriend to convince him to use a condom? We have our first prison intervention. It's called Project START. It's an intervention that has 2 sessions with the prisoners before they're paroled and 4 after. All right, let me go and finish my last 2 slides. And just the first of these is, at the very beginning of our talk, I said that there are people at community-based organizations ask us for resources. So these are the kind of resources we try to put on our website. Starter kits, so that you can have an idea of what to do the first 90 days that you're doing the intervention. Budgets, logic models, technical assistance guides, or evaluation manuals, so your evaluator can think about how to evaluate your program. And then just some final results as to the number of people trained. In the last 7 years, we've done over 700 Debbie trainings, 736, and we've trained over 8,000 employees of over 2,200 CBOs in the United States. But the health departments have also played a major role. We've got over 1,595 employees of over 255 health departments across the country who have been partners. Thank y'all very much.
Thank you, Charles. And I have to say that I didn't really do justice to all of the work Charles has done in his introduction in the interest of time. But if you look at his bio sketch, you can see that he has done his own research, he's published, and he has numerous publications that I would encourage you to look at that are really geared toward adapting research in the practice setting. But we are going to allow a few questions after each presentation, so we have about 5 minutes if people have questions for Charles right now. Okay. Was there, oh, I'm sorry. Yes, Robin.
Sure. The first question is addressing the issue around MSM. And we're trying to address that issue of new interventions for MSM by stimulating the development of new interventions or the adoption or adaptation of previous interventions specifically for MSM of color. So for example, right now we're working with Susan Kaglis to do an adaptation of the empowerment intervention. and to do that intervention in 2 southern cities that have large black gay populations. And so we're trying to build our portfolio of interventions for MSM, but particularly for Latino MSM, Asian Pacific Islander MSM, and African American MSM. We honestly do not have enough interventions, and we do think that we need more in that population. At the beginning of the AIDS epidemic, a lot of HIV prevention, I think, was a natural process of people being shocked by this disease. Their friends were dying. It had an incredible societal impact. And so many of the interventions that were the Debbie interventions were tested and developed prior to the antiretroviral therapy. So therefore, we're encouraging more research to be done in the current generation of how do we help change behavior when people have treatment optimism. Because there is treatment optimism now, but we need to think about, well, how do we adjust for that? How do we make sure that interventions address that issue and are efficacious? Now, the issue of getting physicians to deliver an intervention, when we talk to physicians, frequently, about putting in a 4-minute message into their care when they're treating a patient. One physician told me, she said, I work for a health maintenance organization. We're told we have 7 minutes per patient. She said, so when you tell me I'm supposed to give a 4-minute message, that only gives me 3 minutes to diagnose and treat the patient? She said, that's impossible. And she says, the other thing you don't realize is that alcoholism groups are telling me that I need to screen for alcoholism with each of my patients. The anti-smoking people are telling me to tell my patients to quit smoking, that they found out that 5% of smokers will quit when their physician tells them to quit. And she says, how can I tell people to quit smoking, quit drinking, and use a condom, and also be able to treat the patient at the same time? So we hear that from physicians, and I think that we really have to think about several things. One of the things we have to think about is how to think about the clinic as an organic organization and who in the clinic can deliver messages at what time during the treatment process so that we are able to get messages to patients in the clinic experience. I think by having Loretta Jamott's work with nurses helps give us more evidence that interventions can be delivered by a healthcare team, and I think so those are some of the things we have to think about. The other thing is that physicians tell us they cannot come to a Debbie training. They say your Debbie trainings are 3, 4, and 5 days. We can't do it. We can't do that. So that's led us to begin experimenting now with thinking about how would we do distance learning, particularly for nurses and for physicians who cannot take 3, 4, or 5 days off the job to learn a behavioral intervention. So thank you for those questions.
Thank you, Charles. I think we need to move on to our next speaker, and that will be Barry Callis. Barry is the head of the HIV/AIDS Prevention and Education Unit at the State Department of Health in the state of Massachusetts, my home state. And I was just reading an article about Massachusetts health plan, and I was wondering why I came to Connecticut and left Massachusetts. Massachusetts has done other progressive work as well around HIV/AIDS programming, and Barry's office has adapted several Debbies, but also has encouraged a lot of homegrown interventions and been involved in the replication of some of the Debbies. So I would like to welcome Barry. Thank you.
Hi, and good afternoon. How is everyone? Good, good. Okay. I'm going to test my computer skills here. Just a second. The red box. Oh, I'm sorry. Thank you very much. Okay, just close that up. Thank you very much. Here I am. Okay. So I'm Barry Callis. I oversee the Prevention and Education Unit, thank you very much, in the Office of AIDS, in the Bureau of Infectious Disease. And I'm going to be talking today specifically from a health department perspective in supporting staff in agencies and supporting organizations to implement these science-based interventions in a way that's manageable. Okay. And just for everyone's orientation purposes, the role of the state health department is to plan and respond to the prevention needs of those likely to become infected or those individuals living with HIV. And in Massachusetts, we have 56 funded programs across the state that serve gay men, that serve injection drug users, that serve women, transgenders, and IDUs, and refugee and immigrant populations. The other piece of work that I oversee includes community planning, new pilot initiatives, and adding to the field, adding to the intervention field that Charles referenced. We like to consider ourselves supporting community-based agencies who have interventions, to take those interventions and to develop them further for replication and hopefully future Debbie interventions. I'm going to talk about our Bureau goals, some guiding principles that guide our work. I'm going to give some history and background of some work that we did during 2002 and 2003 to assess the impact of our prevention work statewide. I'm going to give an overview of the steps of implementation, what we did to implement these evidence-based interventions. I'm going to talk about the things that we do to support local intervention development. I want to highlight some of the successes and challenges that we've had, because we certainly have had many of them. There have been lots of things that we didn't anticipate that we had to resolve or organize ourselves around, so hopefully I'll be able to highlight some of those points that will be helpful to everyone, and I have some recommendations to close my presentation. Just to start, the goals of the Office of HIV and AIDS to increase the number of individuals who know their HIV status, to reduce the number of new HIV infections, and to improve the health and well-being of persons living with and at risk for HIV. So whether it's client service work, prevention work, health service work, all of our work in the Office of AIDS is organized around achieving these three Bureau goals. We have a set of principles that guide all of our work, and these principles include a commitment to equitable access to prevention and care services, a commitment to personal autonomy and preservation of civil rights and civil liberties, a commitment to strict observance of confidentiality of personal information, a commitment to maximizing the public investment through smart linkage to other pay sources. We know, and I know that this state knows all too well, the impact of the economy and how that's impacting our publicly funded programming. And we have a commitment to reducing health disparities and improving the health status of all Massachusetts residents. And for the Office of AIDS, that includes gay and bisexual men, refugee and immigrant communities, and racial and ethnic minority populations. A little bit of history and context of what led us to require all of our prevention programs to implement an evidence-based intervention is that we had effective programs that were born out of responding to the initial crisis and were very effective and were making monumental changes with reducing new infections and getting folks into care. We wanted to move towards more longer range prevention programming. We were also experiencing a real uneven experience. We were really experiencing a lot of uneven performance among a number of our programs. Some of the interventions that they were implementing were a bit outdated, didn't really match the needs or the stated needs of populations. We took about a year prior to the release of a procurement to do some assessment of available research, to look at the impact of our current programming, and to look at the data from that programming. We wanted to increase the evidence base of our programming, and we wanted to make sure that we were doing the most effective work possible. This also coincided, so this internal review that we were doing also coincided with the Debbie intervention process. So we thought it was a great opportunity to use the resources and work that CDC had done around packaging and testing some of these interventions and to implement them locally. In making this change from initial crisis response to prevention and information around HIV, we knew that we had some work to do to ready our system for this new set of strategies that we wanted to support. So, in addition to reviewing the research and data from our programs, we had a series of what we call public engagement sessions. These sessions went beyond the general public, but were very specifically targeted to gay men, to transgenders, to injection drug users, folks in recovery, and youth and young adults. We organized sessions across the state to hear from folks directly. What were their needs around prevention? What kind of models would fit your community? We wanted to be responsive to the various nuances in each one of the regions of our state, and there are 5 of those. How many folks here know about community planning or may currently be participating or have participated in community planning? Through a show of hands. Wow, that's great. Okay, so in Massachusetts, we have one community planning group. It's the Massachusetts HIV Prevention Community Planning Group. They advise us on effective interventions and populations that need to be reached with those interventions, and increasingly really guiding us around policy. We took their recommendations, the community planning group recommendations, into this analysis. We also hosted a series of institutes for our existing provider system and those providers who expressed interest in becoming a provider. So we hosted a number of institutes that did very much, they were very similar to Charles's presentation. We went through the available interventions. We had the original researchers available to talk about the populations and some of the implementation strategies that folks were going to need. So we did a lot of training, capacity building, readying folks or readying existing and potential applicants to this new method of doing work. As a result of the institutes, as a result of doing the capacity building, as a result of the engagement sessions, and as a result of looking at the program data and what we thought was effective and those things that we wanted to correct, we established some new service standards. We established some new standards around staff qualifications and a requirement for all of our programs that we funded in the future to have an evidence-based element to their program. It's important to note that the Debbie intervention is not the sole intervention that makes up a prevention program. That's really important to us. We recognize the value of the Debbies, but we also know there has to be an extensive amount of basic education to the population, of a range of client recruitment activities, a range of materials distribution activities. All those things, together with the Debbie, make up a prevention program, not the Debbie in and of itself. Wanted to next highlight some of our local steps for implementation. We hosted and attended local and national Debbie trainings. We were fortunate enough to have enough individuals to fill a 25-person plus training. So in those cases, we worked with the CDC capacity building provider to come and do trainings for Massachusetts providers. In those cases where we couldn't fill a training or where the resources were stretched, we actually sent our staff, including health department staff and provider staff, to some of those national trainings. This was all happening at the time of trying to start up our direct programming, so we had to be very flexible with the time frames when our programs were to start and when folks had the necessary training to implement those interventions. We also learned it was important to provide training on the content. As the CDC trainings were happening, we found it very important to give feedback on some of the currency of some of that training content to make it more current and to make sure that the current standards of practice that we had as a state were reinforced in those trainings. It was really important for us to participate in them. At the close of the vast majority of the initial trainings, we assess the implementers' needs. And by implementers, I mean the staff of our funded organizations. We recognize that the initial training and the tools that come with that training to help implement these interventions certainly were good initial tools to begin to implement, but we knew that folks needed more. So as a result, we piloted a number of what we call technical assistance sessions. So we brought together all of the individuals that were implementing empowerment. And what we did is we had 1 and 2 day sessions where we worked with those folks to make sure that the core elements of those interventions and the barriers that they may have experienced or may be facing were addressed so they could proceed with implementing those interventions successfully. We also, in addition to implementing the Debbie interventions, we like to make sure that we're supporting local interventions that were born out of the community-based agencies and the populations themselves that have shown effectiveness to work. So in our procurement, not only could you select to implement one of the Debbie interventions, but you could also select to implement your homegrown intervention as long as it had a theory basis behind it. In a lot of cases, some of those interventions focused on emerging population needs or where interventions were limited. And I know that we had several interventions that were working with women of color because at the time there were not enough interventions for women of color. We had some of those interventions that we supported that were not Debbie's that were targeted to gay and bisexual men as well as sub-Saharan African populations. In a lot of our formalized venues that we have, so whether it's a conference or whether we're doing technical assistance or training sessions, we, in an ongoing way, solicit ideas from our programs or from colleagues or from researchers locally on promising models. We want to be sure that we take the best ideas possible that are coming from the community and work with those models to formalize them a bit more for replication and for possible dissemination. We've built and sustained a number of partnerships locally with schools of social work, schools of nursing, and public health, with researchers and interested individuals in those institutions who have worked with us to take some of those interventions and prepare them ready for packaging and dissemination and replication. We also, with those interventions, we want to be sure that we're presenting initial findings on those interventions at conferences, and we're eagerly looking forward to replicating those interventions when the opportunity is available. Expanding programming options. Again, we do a lot of work to seed intervention development. We participate in replication studies. We participated in Voices Voices. We participated in healthy relationships. We think that's a really good idea and way to be part of the research project process to help shape the final product. We have recently conducted some formative planning for HIV-positive individuals and refugee and immigrant populations to aid in intervention development. And I can't underscore enough the importance of maintaining local partnership for replication studies. Lessons learned. Commitment from partners is critical. Commitment from nonprofit organizations, from staff and communities are critical to implement these interventions. Some of these interventions are very complicated. Some of them don't always work in the real world setting, but implementation and success is possible. Sustained technical assistance is essential. So beyond the training, TA is needed. We've been very creative in sharing resources, whether that's bartering exchanges between research institutions, training vendors, and the health department. We encourage adaptation when it's indicated. Currency is essential, and it's really important to invest in ongoing workforce development, helping those implementers continually develop skills to implement these interventions with accuracy and fidelity. Among our successes, we have a variety of evidence-based interventions that are implemented locally. We've increased the experience with these interventions, having done these over the last 4 to 5 years. We have seen the evidence of value to community and clients. And these interventions have been very important bridges to comprehensive infectious disease prevention, screening, and referral services. In terms of recommendations that I would have, we really believe that interventions need to be increased that meet comprehensive sexual health, compulsive behavior, and infectious disease prevention, screening, and support goals. These interventions certainly are an important goal into meeting whole person needs, and we want to support the comprehensive nature of future interventions. Increasing the availability of these interventions that integrate priority health concerns and life circumstances, and I was delighted to see some of the, among the 8 newly publicized DEBI interventions, incarceration in individuals who have experienced trauma. There are interventions that are specifically geared to individuals with those life circumstances. We have some quality assurance procedures in place. I'd like to see more, particularly in the area of individual and group education. We are revising our data collection tool for prevention services. We hope to have that done in the next year. And again, sustaining collaborations with community-based agencies and researchers. I'm seeing that I have 1 minute, so I'm going to skip this, and I will want to make sure that this presentation is available to the organizers. And thank you very much for your time and attention. We have a few minutes for questions, if there are any. Yes? Are there DEBIs for heterosexual men? Yes, there are. And we also have non-DEBI interventions that we're implementing locally for heterosexual men. Maybe, Charles, would you like to highlight some of those interventions for heterosexual men?
Sure. Voices is our primary one for heterosexual men, but we are, not next year, but within probably about 18 months, we're also going to be diffusing another one for heterosexual men called NIA. African American, it's really designed for African American heterosexual men.
Yes.
Barry, thanks for your presentation. It was really wonderful. Just want to give you a shout out to as a native of Massachusetts, now living in Connecticut. But I was wondering, some of the newer interventions that you guys have developed, would those be available for us? I sit on our community planning group, so.
We are delighted and happy to share any of these interventions that you're interested in. We have one for sub-Saharan Africans. We have one for HIV positive African American women that are 40 and over. We have safety net. So we have a number of interventions that we're more than happy to share with you.
Great. I'd like to connect with you afterwards.
Sure thing, absolutely. Other comments or questions? Yes. Mm-hmm. Mm-hmm. Yeah. Mm-hmm.
you're promoting and also what you think about the researcher's responsibility to develop interventions as we move forward that are easily integratable into the care or CBO setting.
Okay, thanks for your comment and questions. We think it's absolutely critical to be sure that that we continually solicit ideas and take non-Debbie interventions from the field, whether we're funding the program or not, and develop that as much as possible to ready those interventions for further study of effectiveness and for possible future replication. So we're lucky enough in Massachusetts to have a number of universities and colleges. We have ongoing relationships with researchers for other projects, and we're always looking to build our connections with them around taking some of these interventions and readying them enough to become a Debbie intervention. If I overlook some of your question, help me out. In many cases, these researchers are applied researchers, so they're working, in the cases where we've taken these interventions and are readying them for a possible Debbie implementation, these researchers are already in the field working with the populations and are doing other related research, and so it's an outgrowth of current work that they're doing. So we're lucky enough to have enough individuals locally to take these ideas and mature them and run with them and develop them. We also have had a great advocate and colleague with Charles being at the CDC. He's heard from us on a number of occasions with some interventions that we're really excited about, and we've worked with him with him and linking him to the researcher so that there can be a clearly understood and coordinated path to development. So did that answer all of your, okay, thanks. Okay, thanks very much, everyone.
You ready?
Okay, our next speaker is Soraya Elcock, and Soraya is the Deputy Director for Policy and Government Relations at Harlem United Community Aid Center in Manhattan, or in New York City, sorry. Yeah. And she is going to talk with us about the experience, the authentic experience of adapting evidence-based interventions at the community level. But before Soraya comes up to the microphone, I have to say that I am both very pleased that she's here and relieved, because up until the 11th hour, we weren't sure if she was going to be able to wrestle herself away from the New York State Legislature, where she was warding off some apparently regressive legislation on HIV testing. And, such is the reality of people who work on the policy end of things. But Soraya has a long record, and if you look at her bio sketch, of working as an advocate and activist in communities of color on issues of HIV that go back to 1992, has held multiple positions, including running about 11 different programs, and I think can tell the story of working before you had evidence-based and then making that transition. So welcome, Soraya.
Thank you so much, Elaine. Okay, so I need to make two confessions, first of all. One, I'm going to have to read and hit the button and speak simultaneously, so it might be a little bit ugly. And two, I really want to, while I thank Elaine and the group for inviting me here, and I really am excited to be here, I do want to do what my nephew would call a shout out, because you were talking about the difficulty in getting me here. I was supposed to be in DC, so they booked me from DC. Then I was like, oh no, I have to be in Albany. No, I think I can go back to DC. So Sandrine, I think, booked me about 6 different places. And when she met me here, she didn't spit in my face. So thank her, and thank you for all of that work. So, okay, let me first find me. He said, just hit the button. Go to the X, right? I heard my colleague in the room say, hit the red X, hit the button. Oh my God. Okay, and I just hit and do this. How do I move it forward? God, it's sad. You're all frightened, aren't you? And I can't tell you how much of your tax dollars I get to play with every day. Okay. Okay, so, and just, now I go arrow to arrow. Hi. Yeah, my name is Soraya Elcock, and I am currently, we actually just went through title changes in the organization for the executive team. So they now call me the Vice President for Policy and Government Relations, and my salary didn't increase at all, and my mortgage company, neither my partner cares what my title is, but we now are called Vice President. The first slide really just show the scope and the breadth of the work, or what the organization currently looks like today. You've got the 3 circles, and they're all interlocked, because what that really does is demonstrate one of the guiding principles about the organization. So healthcare, prevention, and housing are the core areas of the organization, but unless we integrate the work within all of those 3 divisions, the agency itself doesn't work. We've actually had a really interesting development. Harlem United was founded around 1988 at the height of the HIV/AIDS epidemic, and I love how we got founded. We're in Harlem, which unfortunately back then and even today is talked about and considered the epicenter of the epidemic in New York City. And what we were facing was an epidemic that nobody really understood, and people were running down, what we call downtown, below 125th Street to get services. So we were founded by actually 2 gay men, women religious, and some priests, because folks were running around going, what is this, what can I do? And a gay HIV positive man reached out to his pastor and said, I need help. Specifically, we were designed to really serve folks who had suffering from homelessness, mental health, and substance use issues. And pretty much today, that is pretty, it still continues to be some of the issues that the clients that we deal with are struggling with. Considered the agency of last resort for the medically underserved in Harlem. When we started the agency, we were in the basement of St. Philip's, I think it's called, church, back in 1988. The running joke is that the counseling room was actually the men's gym, and actually still smelled like the men's gym, but that was the way we actually began, because we just had to step out to do the work. We were founded to address the lack of response from more established providers, because the folks that we dealt with, the folks that we continue to serve, are what folks talk about as the hard to reach. Once you reach them, they're hard to engage. Once you've engaged them, they're hard to keep in care because of all of those multiplicity of issues. So from 1998 to about 96, really small paraprofessional organization. We had a couple of units of housing programs, and we had what we call social daycare. Because what we were trying to do is, since so many of our clients were struggling with substance use, we created that safe space so that folks would, let's say, use all day. You got to Harlem United, we were called the Upper Room AIDS Ministry. At the St. Philip's basement, you were able to get a hot meal, a sense of community, and some counseling. But in 1993, the board of Harlem United was pretty ballsy. Can I say ballsy? I can say ballsy. It was pretty ballsy, and we got licensed to create what we call an adult day healthcare center. There are about 8 of them that exist, and it's a model that only exists in New York State. And everybody looked at this crazy little tiny mom and pop organization in a basement and said, you're gonna do a license program? But what has always driven Harlem United is, first and foremost, if it's needed, we've got to find a way to create it, because as I said before, folks didn't have the capacity or actually want to deal with the folks that we saw in our organization. It was actually a bold move to create an adult day healthcare center, to get a license for it, and a lot of more established organizations were a little risk-averse because it's a really risky model. Medicaid-driven, the risks are incredible, but it was clearly what was needed. At the time, it was also really visionary, because in 1996, the advent of HIV/AIDS therapies hit, and what we were able to do then is create, in a grassroots community-based organization, healthcare for those individuals we serve. I mentioned before that we were called the Upper Room AIDS Ministry, and in 1995, we changed our name to Harlem United Community Aid Center because everybody thought we were somehow a religious organization, and not that there's anything wrong with religion, heathen that I am, but we wanted to make sure that there was a name that was more reflective of the organization. And the reason we were originally called the Upper Room, I said before, we were founded by ministers and women religious, and where the organization met was in the upper room, the top room of a liquor store. And there's a part in the Bible that talked about Jesus lifting people from the upper room where you gave people from turning fear into hope. So in this upper room, what these folks were doing for people in Harlem living with HIV/AIDS was trying to create programs and services that would turn fear into hope. So we changed our name, but kept that same mission around fear into hope. The Adult Day Healthcare Center, the ADHC, really kicked us and gave us the ability to seize upon medical advances. So we were the first Adult Day Healthcare Center to really add primary medical care. I think we did it around 2000. We did direct observed therapy, and that's not just around HIV/AIDS meds, but that was also around mental health meds from school that our clients are struggling with. We're a founding member of Vida Care, which is a special needs plan for people living with HIV/AIDS. And in 2007, we opened the Spanish language, is the first and only bilingual adult day healthcare center in the country where people of Spanish descent are able to benefit from an adult day healthcare center. And then we got a federally qualified healthcare center. In about 2007, we were designated as a federally qualified healthcare center for the homeless. Okay, here's the part that I love the best. I mean, it's all great, but I got to Harlem United in 1999, and I got there as the director of the Prevention, Education, and Policy Division, which is what prevention at Harlem United was called at the time. And the reason I went to Harlem United was in the past I did policy work. I was at a place called Federation of Protestant Welfare Agencies, and my job was to do HIV/AIDS policy for African American and Latino women and children, a lot of stuff around permanency planning, the early years of the epidemic. And what I was missing was kind of the program, the folks, the people. So I could do policy, I could do analysis, but I wanted to get with the folks who I was writing these policies for or doing this advocacy for. So I went up to Harlem United in 1999, and my job, my mission was to grow our prevention division. At the time, we had 2 small contracts, and I left the prevention division because it got too large and the policy got so large in 2007 and focused just on policy, where we had 14 programs. Now, I don't tell you that to brag. I was actually in the right place at the right time, because in 1999, the Minority AIDS Initiative had hit, and we wrote 7, our proposals, hoping to get 2, and we got 7. And I was too dumb and young to realize no sane person starts 7 programs at once, right? I thought, if you build it, they will come. If it's based on research and data, of course they're going to your programs. Yeah, short-balled and insane. But back then, one of the things that was really something about the organization that really appealed to me was there was always an emphasis on where do we need to go next. So even before CDC talked about advancing AIDS strategies and HIV/AIDS counseling and prevention for positive, by the nature of being in the work, you could see that's what we needed to do. You could see that's where we needed to go. So the prevention division started doing that. We were one of the first organizations that made sure everybody became a certified pre- and post-test counselor. We built in interventions pulling on the Debbie programs because we wanted to have the ability to actually create or pilot what we thought was necessary. And I think the biggest, most exciting thing we've done recently is in 2007, we married an organization called Frosted, which had been established back in the 80s, and it focused on HIV/AIDS and, what are they called when you sell it for money? Sex workers. Ooh, I need a nap. And the reason we married Frosted had a syringe exchange license, right? They functioned downtown. And by 2005, 2006, we're sitting going, how do you do mobile HIV testing without doing Hep C screening and syringe exchange all in one van? Because some of the funniest things is to go uptown in Harlem or most neighborhoods, and you'll see the syringe exchange van lined up behind the HIV testing van, lined up behind the Hep C screening van. And what we didn't want to do was have to go through the community board to get a syringe exchange license. I'm just way too old for that kind of ugly fight. And Frosted needed a partner because it needed evaluation and research. So it was a great marriage. So what do we have now? This is pretty much what the prevention division looks like. And I'm going to focus when we look at research and interventions on the testing department and the education and training department. Our Frosted at Harlem United is really where our healthcare prevention services for injection drug users live. And in education and training, that's where some of our behavioral interventions live, along with some of the Debbies that we do. And in testing, we look at different testing strategies. And one of our homegrown HIV testing strategy program live in testing. Let me just make sure I've told you everything that I wrote on my paper to tell you. Okay, so I put this slide up because it's really important. I think it's the reason we're able to do evaluation and do some of the research that we do. In 2003, between 2003 and 2005, we made a significant investment in evaluation and research, right? Not because CDC was saying we need to have evaluation, you have to data. If you're directly doing the work, I know a lot of times you get the money, you implement the program, and you have, if you're lucky, because when we were small, we didn't have the evaluation capacity, but you did your basic pre- and post-test survey. But there's nothing more painful than spending, my mother likes to call it her tax dollars, for 3 years on an intervention where you want to make the difference in somebody's life to find out after 3 years you didn't. And what we wanted to do was have the ability, as we went along implementing, creating, and operating these programs, how do I need to change it? How do I need to fix it? What is this data telling me? What's working and what's not working? So in 2003 and 2005, my ED and I said we got to make the investment. And so within each of those 3 areas, prevention, healthcare, and housing, everybody has evaluation staff. The evaluation model that we use is really a management model, and we call it the triad because it has 3 parts. I actually call it Father Pat's Holy Trinity because my executive director was an ex-priest, and this is his Bible. This is his Holy Trinity. This is how we manage programs, we evaluate programs, and we're able to create other programs based on using the triad. The 3 components, and tell me if I'm going too quickly. Good, because you're probably all napping, right? CQI, our evaluation model, one of the guiding principles that we manage programs by. We don't even call it evaluation model as much as we call it the management model. Every program within the agency, so when I showed you all of those programs on the first slide, every single one of those programs, whether you're in healthcare, housing, or prevention, use the triad. Every staff is involved with the triad. So continuous quality improvement really focus on the program's performance. But what we do is from the outreach worker to the program director, all of those people create the indicators that they're going to review. And once a month, you pull charts randomly and everybody reviews them. We don't focus on who the person is who did that deliverable or didn't do it. It's about assessing the program as a whole. In our data-driven administrative supervision, the focus is on the individual performer. I'm not reviewing it for did you do it well or did you not do it well. I'm reviewing it for did you do it. Did the assessment happen? Did the reassessment happen? Did you link the client to care? It's an individual performance. And then the third arm of the triad is our clinical supervision, which is really all about building and developing clinical skills. So usually the way it works is the data-driven supervisor would refer that particular staff to the clinical director, because there's some clinical work that the person needs to develop in order to do his or her work better, which comes back to make sure then the program, when you look at continuous quality improvement, if those two arms are working, you'll see the benefit in your CQI when you review your charts. So, as I said, our evaluation is not just about the program that you're currently looking at, but it's also the ability to create better program models. And within the 3 division, we've seen some of those take place. In prevention, we actually, which is one of the things I was going to show you, based on our evaluation of some of our programs, created a risk-based and geographic-based HIV testing, and was able to compare the two to see where do I get better outcomes, where's my seropositivity rate better in terms of risk-based and in terms of geographic-based. In healthcare, we were able to create what we call the full-service medical home. We did a little program, a survey that focused on the issue of aging, which allowed us to provide primary medical care that surpassed 16 of the national HIV-QoL indicators. And the reason I talk about it that way is because that's important for staff to understand. They need to benchmark their work against something. They need to feel that I'm a grassroots community-based organization, but that doesn't mean data is not important to me. They get to see how data and research gets translated from that guy or that girl in the white coat, how you can translate that stuff, how you can use your own evaluation tools and directly see the impact and the change in your client life that you get to drive. And in housing, it was really exciting for us because we have about 500 units of supportive housing, and you have a housing contract. Every housing client gets treated the same. I do X number of home visits for all 700 people. And at some point, housing staff said, but wait a minute, Soraya's been with us for 10 years. Knockwood, she's healthy. I go to see her. She's taking her medication. She talks to me about her issues with her children, her psychosocial. Why am I going to see Soraya every week? As a matter of fact, she's got a part-time job. But over here, Sonia, who's also been with us for 10 years, failing on her treatment, still struggling with substance use, her partner's still kicking her butt. I want to be able to go see Sonia twice a week and maybe see Soraya once a month. And through testing that, piloting that with our evaluation, we were able to get our funders to let us do that. They didn't change the scatter site housing model program for the whole city, but we had data enough for them to say, okay, go ahead, pilot it. Let me see what kind of outcomes, health outcomes you get when you focus on the critical clients based on what you see in their charts in terms of their health care. Okay, so a couple of examples of how we took research into practice to serve people with HIV/AIDS in Harlem. Now, we talk a lot about this because I do a presentation in New York City for our prevention planning group that I was the co-chair of. And at this point, you talk about it and people go, wow. Now, let me tell you, it wasn't pretty, okay? Taking research into your community-based organization is a cultural shift. This looks all pretty on paper. Took us a year and a half for folks to really get, understand, first, the triad, and then understand why the research is important. Why are we going to take these Debbie things and practice them? Because we know there's a historic distrust of researchers and folks who do the work. And unless we start having those hard conversations, then we don't really bridge that gap. And community-based organizations don't get to see the benefits of research. Researchers don't get to really experience, which is a powerful experience, what it's like to do research at that level, living with those people, hearing from those people, and being able to take their day-to-day experience, maybe going back and tweaking your tool, tweaking your document based on what's really out there. So it sounds pretty, it wasn't pretty. It was a long, gruesome process, and it really was about doing a whole cultural shift within your organization. And I think it's a shift that still has to continue. I did a presentation about the importance of research about 6 months ago, and actually had a colleague in another organization say to me, "Oh God, Soraya, you know, you're so good, you're so smart, I can't believe you've bought into the white man's model." And I was like, dear God, what did I miss? What have I done? What did I say? And in her head, any type of evaluation is a Eurocentric philosophy process that doesn't really speak to how we should do the work and what's happening. And after drilling down and having a conversation with her, I said, you know, here's what it is. It's the early 80s. Folks are dying. We don't know what's going on, and everybody rolled up your sleeve and you jumped in and you just did what you needed to do, right? Back then, you didn't know what the H meant, what the I meant, what the V meant, right? But you know, people were sick, people were dying. Advocacy grew up. A real strong commitment to community advocacy grew up, because remember, we had a president who couldn't even say HIV for 5 years. So I get that sense of mistrust. But there's a thing my grandmother always says: when you know better, you do better. And in 2009, we know better. In 2009, we have research. We can do research. We have to have the conversations that say the epidemic doesn't look the same as it did in the 80s. And I see she's writing on her pad, so I'm speeding up. So, I want to talk about two Debbies that we've taken a look at: healthy relationships and adapting it for African American MSMs, popular opinion leaders that we adapted for African American MSM. Someone talked about not having enough MSM Debbies, and I know more and more coming. Back in the day in 2004, when we first started this, there was only many men, many voices. And if you look at the data, there is no way you can't see that there's a big need for more interventions for MSMs, and especially in Harlem. Historically, we serve a lot of African American and Latino men who have sex with men, and they're a huge part of our population, and there is a huge part of the community of East and Central Harlem, although they're way underground. And you'll see when I talk about POL, what we did was adapted and found out the venue that worked for us was the internet. And then I'm just gonna briefly talk about social networks for African American women and MSMs. I know you all think we're a little MSM phobic, right? A little obsessive, okay. And some data we got from that. And then the one that I'm really excited about, Blocks, which is a program we got a little bit of money to do from the MAC-AIDS Fund to pilot it. Got some really interesting data, which I apologize I don't have for you today, because the evaluator wasn't able to get it to me because she didn't know if I was in DC here or in Albany. And it really focuses on zone-based testing versus risk-based testing. So Charles did a great job of telling you about Popular Opinion Leader. It's a community-level intervention that really focuses on identifying key stakeholders and the influencers in the community, right? These are people who have the ability to influence community norms in their particular neighborhood. The justification for that, formative evaluation, the reason we adapted it for the internet is because the formative evaluation that we did showed that that was the most effective way to reach young MSMs, right? So everybody knows that the issue around MSMs and HIV/AIDS changes like everything else, and has been changing for years. And in the early years of the epidemic in Harlem, you knew where the sex clubs were, right? So we had all different interventions that we tried. You'd go into the sex clubs. What's happening now is that stuff has moved more and more and more and more underground, right? So the hot spots, the zones where MSMs are kicking it, changes every 20 minutes. What we realized, too, after doing some research, was a lot of that stuff now is happening on the internet, right? Our earlier speaker talked about the power of the internet to misinform. Well, the power of the internet, there's about 3,000 websites. I don't even know the technology, but we have connections to them all, where that's where young guys are now cruising for sex. And so we adapted POL for the internet. The objective there was to provide messages and conversations to promote safer sex behaviors. When you looked, and we did some of our evaluation work, a lot of barebacking is going on. A lot of young men think, somebody earlier talked about treatment, people thinking treatment is here, so I don't need to do the same level of HIV prevention. I think the scariest statement I ever heard was I was part of some of the formative research on this, and the 17-year-old who said to me, "Oh, Soraya, I get it, I understand, but you don't get it. When I get HIV, I'm just gonna take the pills." Now, this was only about 2 years ago, so it's not like, oh my God. 2 years ago, when I get HIV, I'm just gonna take the meds and then I'll be fine. And on another note, which is another conversation, the other piece I hear all the time from folks is, because you can get services that way, right? We've created a whole system of care, which we should, for people living with HIV/AIDS, but sometimes when you do the work in Harlem, we have a federally qualified health center to target homeless people. So they don't have to be HIV positive, but they have the same issues that Soraya has who's positive. So Soraya is black, she's 30 years old, she's poor, she's undereducated, she's positive, she's gotten her behind beaten for the last 20 years. All of those psychosocial issues that we know drive the epidemic. And here's Sheila, black, mother, 30, she look exactly like Soraya, except Sheila is not HIV positive. And I don't have a system of care for Sheila. So when Sheila says to me, "Damn, it looks like a little HIV is my best way to get some housing," the back of your neck should be freaked out, which it is. But those are some of the issues when you look at the dynamic in Harlem. Just quickly, this is a snapshot of our POL training. You can just see pre the training and post the training, people's knowledge went up. Debbie, and I'm doing this quickly because I really want to get to the other one. So the other Debbie that we looked at was healthy relationships, and we did this intervention for HIV positive men and women. We looked at it for MSM, small group intervention. To date, 103 MSMs have gone through this intervention. Now, here's what's really interesting. Here's what I love. This was a failure for us. A failure in terms of the fidelity that you need to truly adapt. Bugs. We didn't figure it out. It didn't work, whatever you want to call it. But the beauty for me was working with the CDC to take what we had done to almost model what adaptation should look like. So one of the hardest things when you're a community-based organization and you're trying to adapt something, there are all of the key elements you have to for it to be evidence-based and it to be true, and that's important to me. But what do you do when you screw up somewhere, but you already have 60 people in some kind of intervention? You started doing something, you messed up somewhere, somebody dropped the ball, what does it mean? Well, CDC was able to come in and take what we did and helped us come up with an adaptation of an adaptation. So, you know, they're critical things you can't do. They're critical do's that are elements of the program. But if you did something, they call it red light, green light. If you did something that was different, one of the elements is 3 sessions, but based on the folks you're dealing with, they said, "Ooh, I need a whole other session to help me maintain this behavior." So you put another session in. Right? Green light, it's still evidence-based. But what happened when that person says, "No, a workshop doesn't work, it needs to be a community-level intervention. Instead of putting 6 folks into the workshop, we need to make this a 30-person. That means I screwed up. That means I don't get to continue the work. They call that red light. So you're not really sticking to the Debbie criteria, but you're still doing something. And how do you then come in and evaluate that and model that so you can have some outcomes that can help you possibly build something else? And we used our triad to help us work that, and the CDC came in to give us the ability to do that. So you're still doing something that's evidence-based, even though it doesn't follow the exact adaptation that you had started to do. So just some preliminary results of our adaptation for MSMs that we were trying to do. So you see the 36% pre-implementation, post-implementation it went to 40, and then this one is about how do I inform my male partners about my status? And the thing about these interventions is how do you do the follow-up? The follow-up is what's really not exciting to me, but really important to me, because while you have somebody in your intervention, and then a couple months after your intervention or week, I think it's right there. It's easier to hold on to, especially at a Harlem United. We're able to pull folks into other pieces of the agency, right? So you're in prevention, you're doing this, I don't want to lose you, I put you in my food and nutrition program so I can hold on to you and give you a safe space. But what I want to make sure that 6 months from now, you can still absorb, use, and your life is moved by intervention, and we can see some of the results there. So this one I find really interesting. This is a risk-based approach around your social networking. So on the top, what is that, the left-hand side? That represents the initial recruiter that we got from social networking, right? Because social networking says, you're not going out to find me strangers to bring in for HIV testing. You're bringing me your friends, your lovers, right? You're bringing me the people that are really closest to you. So that recruiter went out and we initiated him as a recruiter. He identified, whatever the number is, 6 HIV positive individuals. He in turn recruited another recruiter here who identified 10 individuals, but they're all, if it's not darkly colored in, that means those individuals he identified were not HIV positive. So over here, my original recruiter from his social network found 1, 2, 3, 4, 5 HIV positive people. From that, was able to find another recruiter who identified folks from his social network, although they were not positive at the time. And that's how it continues and grows and grows and grows, because it's the social networking that we realize we need to infiltrate. We did high-risk clients tested through social network, had a positivity rate of 6.3 for women and 14.6 for men. Social networking is one of the strongest interventions in identifying new HIV-positive individuals. So, zone-based approach, which is really what we call blocks. We took a look, about a year ago, we got a little bit of money to pilot what we call blocks. And blocks is really an approach to testing that's geographic, I don't want to say versus, but compared to risk-based testing. Because more and more, when you look at the epidemic, HIV is as much about who you are as where you live, right? In Harlem, you're talking about high prevalence, high incidence. You're talking about social networking. Chances are you're going to run up against some HIV. So what we wanted to do, and in Harlem, people aren't assessing themselves at risk. So what we wanted to do, because we had these high numbers, was say, well, rather than just doing risk-based, let's identify zones. Let's identify the hot spots, using peers, using influencers. Tell me where they're doing the do. And what we did was take a 20 blocks radius, and we did an entire intervention called blocks. So for 6 months, I am in that 20 blocks radius. I'm working with the churches, the local drugstore, the supermarket, and I'm going door by door, block by block, to educate and offer HIV testing, versus identifying that person risk and bringing them in for HIV testing. Oh, I have a minute. So I'm just going to jump to conclusion to show you all strategies of these different testing, risk-based, social network, zone, they work. They work for different populations. However, what we've seen is that geographic approach is responsible for the larger proportion of the total HIV-positive people identified, especially when you are in an area, or I think the way the epidemic is today, many people are always telling me they're not at risk. I'm not at risk, I'm not at risk. A lot of people are testing late. 28% of the folks in Harlem testing for HIV are finding out they have AIDS at the point of testing HIV, because their assessment was they were never at risk. But what I'm able to do with a geographic-based approach is reach those people, offer them HIV testing so that they can know earlier, get on treatment earlier, save their lives, reduce the community viral load in their community. It's actually, another interesting thing about this is it's helping us to really create our policy position around HIV testing. There's nothing sexier to me than when program research connect with policy so that you can create something that actually makes sense. You'll still have a fight because we're stuck with a lot of policies that were created the early years of the epidemic that people haven't quite done a paradigm shift on. They can't let go of it. And HIV testing legislation is one of that. It was the reason I was having a hard time figuring out I was coming today, because we're trying to get legislation that relieves the barriers of HIV testing, the pretend pre-test counseling, the pretend post-test counseling, and trying to get HIV testing to be part of a routine health care so that the doctor doesn't have to assess a risk, the client doesn't have to come and say I'm at risk. As part of my routine health care, when you look at the epidemic of HIV/AIDS, everybody gets asked and everybody gets tested. I'm sorry I went so fast. Look, my new title is on the paper. Thank you so very much. Take care. Hi, questions? Cool. Okay, thank you. Yeah.
All right, thank you all, and thank you, CIRA, for that great presentation. I am happy to introduce again Seth Kalishman, who some of you heard this morning when he spoke about AIDS denialism, and he has a new book that's coming out, and he's dedicating the proceeds, so we encourage you to buy that book, and there are cards, I think, around on the tables. Do we have that? Yes, there are. Anyway, Seth is going to shift gears and talk about a different subject. Seth, as I had mentioned earlier, is a professor in the Department of Psychology at the University of Connecticut and has done extensive HIV prevention research as well as research on HIV care. He's going to talk today about Debbie, that he has been involved in surveying community-based organizations that are actually implementing this Debbie. So thank you, Seth.
Hey, you learn a lot, you know, coming to things like this. I had thought that Debbie actually stood for denying the effectiveness of behavioral interventions, which is something that I see policymakers engaging in a lot, the denial of effective behavioral interventions. I'm looking for recently, let's see. Well, where'd you guys put it? Well, let's do it this way. Let's try it this way. There we go. There it is. All right. So, yeah, I can talk to you about a study that we did to look at some of the technology transfer issues around a particular Debbie called Healthy Relationships. How many of you have ever heard of Healthy Relationships? They were listening to you.
Oh, I'm sorry.
No, that's good.
Oh.
That's where they heard of it. They heard it from you. All right. Well, then I don't have to actually talk much. So the research that I'll present to you is actually a product of our research group called the CIRA Project, which actually exists in Atlanta, Georgia, and runs out of the University of Connecticut. And it's completely sponsored by the NIMH, by the National Institute of Mental Health. Now, you know, the early days of HIV prevention were really focused on delivering HIV prevention to all people who might be at risk for becoming infected, and the CDC changed course in 2003, really shifted prevention priorities towards detection, testing people, identifying infected people, getting them into treatment, getting them into care, getting them into prevention services. It's a totally different approach. It's called positive prevention. That's what I call it. I like to call it positive prevention. And this particular intervention falls into that approach. And so there's this whole process that this intervention went through that I had very little to do with. You might notice I like our marketing poster, which is basically popcorn movie theme. That's what we used in our research study to market the intervention in Milwaukee and in Atlanta. But the people that are in that picture actually were working in Milwaukee. It's kind of weird. But the research was done in Atlanta. And that's the image that the CDC uses to market this intervention, this Debbie called Healthy Relationships. The intervention model is really geared around social learning theory, a coping adaptation of social learning theory, social cognitive theory. It's a 5-session small group intervention that's delivered by peer and professional group facilitators. The intervention focuses on disclosure decision-making skills and safer sex negotiation skills. It has a heavy reliance on DVDs, not videotapes anymore, stupid, and movie clips for using movie clips from popular films for doing the skills training. It's a highly interactive, group-centered, video-based skills-building intervention. We always like to talk about it. And these are the core elements. This is when Moses descends from the mountain with the tablets. These are the core elements, not to be violated. Despite their arbitrary and sort of out of my hat basis. So healthy relationships defines stress and reinforces coping skills for dealing with stressful situations. It uses behavioral rehearsal and role plays to do focused feedback-based coping skills training. It teaches decision-making skills, particularly around HIV status disclosure. It provides personalized feedback reports. This is a core element to help motivate behavior change. And it uses movie clips to set up scenarios for disclosure and risk reduction role plays. That's correct, right? Because I wouldn't know. I pulled them off your website. All right. Okay, movie clips are really an important feature of the intervention. So when people kind of have been trained in healthy relationships, it's kind of the thing that they remember and know best, probably. It's kind of a cool thing. Big focus in the intervention is around dealing with disclosure, decision-making skills, which is kind of a stigma-related thing. And the disclosure decision-making skills move from family and friends and other people in your lives to partners. These personalized feedback reports were considered important when we did the research, and as it turns out, they might be a little bit complicated to implement in practice. The skills building part is highly interactive, and so it involves kind of hands-on, literally, skills training. I know that picture, it's really latex. You have to trust me. It's really a rubber penis. And this is the package. It's like, poof, you know, hocus pocus. These people at CDC and the people they contract with, they put all this crap that we kind of just used, and they make it into a really nice thing, and it's like a really cool thing. Now, we did not do the Debbie. I know you're going to think this is a joke. The people in Dallas did the Debbie. It's kind of like Debbie does Dallas. Well, Dallas did the Debbie. And it was actually produced by not the medical school, the medical school in Southwestern Texas Medical School in Dallas. They did the Debbie. Ann Freeman's group really knows how to do this stuff. I don't. And for better or for worse, and I think for better, I think they did a really great job. All right, so what is the study that I want to present to you today then? The study I want to present to you today is a little study we did over the summer, last summer, to take a look at maybe how agencies are actually implementing this particular Debbie. And it was kind of a cool study for us to do because people at the New York State Health Department were interested in the answer, and people at CDC have been kind of interested in the answer. And I frankly had to have something to talk about when people ask me to talk about healthy relationships because I haven't done anything with it since 2001. So I had to come up with something that I could present at a conference like this. So what we did was we asked the CDC, and we got no resistance. They were incredibly helpful. Charles Collins, you were great. They sent us the list of all of the agencies that had been trained in healthy relationships. And so we had the universe to sample. And it was, between 2005, when they started the training in this Debbie, to April of 2008, there were 63 trainings that were attended by just under 1,000 people, 999 people, working within 235 ASOs and CBOs and 64 health departments. That was our universe that we were able to try to contact all of those agencies and ask them about their implementation with the Debbies. So with this Debbie. So what we did was we actually called them. We tried to connect with them. We emailed and called them, and that's how we did the study. So what we were able to do was try to sample. Not all these agencies actually implement DEBIs. Some of them are training, and some of them are like health departments that oversee. Not everyone trained in healthy relationships actually would be an end user. But really what we saw was, there were 999 total persons that were trained, 299 agencies, CBOs and health departments that were potential end users, although some of them we learned actually would not be appropriate end users. We were unable to contact 139 of them. And we had people that were scheduled, but they were never completed. We found agencies that were out of business. Some had refused. A few didn't want to talk to us. But we ended up with a sample of 111 community-based organizations, 8 service organizations, and 11 health departments that were appropriate end users for healthy relationships, and we completed interviews with them. Of those, 93 had implemented healthy relationships, and 29 never implemented. They were trained, but they didn't want to do it. Okay, so when we look at the people, these agencies, and again, the agency is really the unit here that we were interested in. When we look at the agencies that said they didn't implement, they were trained, they were interested, but they didn't want to do it. The answers, we asked them a number of reasons why that might be. And the top 3 reasons, 74% of these 29 agencies that didn't implement said that healthy relationships did not meet their agency's needs and priorities. 63% said it was too difficult to implement, and 63% said it didn't meet the community needs. And of course, they could say more than one thing, obviously, okay? But the big things here are, it wasn't a really good fit and was too cumbersome to do and didn't meet our agency's needs. Okay. Now we asked them about the very specific activities in healthy relationships that actually reflect the core elements. So these are the activities that are where the action is in the core elements. These are the things that they're really supposed to do to maintain fidelity to this intervention. And what we found actually was a good number of agencies changed the activities, and a smaller number, but not insignificant, dropped the activities altogether. Now, the way that healthy relationships is structured is the same activities are repeated 3 times. They're repeated for disclosure, decision-making to family and friends. Then those same activities are basically reframed and done for disclosure, decision-making to sex partners, and then for safer sex decision-making. And what we see is for the family and friends, the PFR, the personalized feedback report, is the most likely to be changed and dropped. The decision grid was changed. So these are like core element activities. There's a lot of adaptation going on and some dropping. And when we ask them why, the most common reason why is to make it fit the community. There's a theme emerging here. Same thing with disclosure to sex partners. The PFR, the personalized feedback report, which is a core element, is most likely to be dropped and very likely to be changed. The movie clips for the skills training are also likely to be changed, and that isn't using different movie clips. It had to be the way that they use them. Okay, so they're adapting the way that they're used, because they can choose from a lot of different movie clips. That's not the point. It's how they use them. And the same thing for safer sex. What we have is agencies changing and dropping the same activities across these domains, and for the same reasons, to simplify or to improve the community fit. When we took all of those ratings of those different factors and we put them into an analysis to see which ones were the most significantly different from each other in terms of their importance for changing or dropping activities, it is to improve community fit and to simplify. Those are the 2 factors that were most important in adapting and dropping core element activities. Now, we asked these agencies about their perceptions of fidelity and what their funders are basically telling them to do. So these are perceptions of fidelity among agencies that adapted the intervention and agencies that implemented it with fidelity. Okay? So we had some agencies that said, we do it exactly the way they told us to do it. Those are implementing with fidelity. Then we have those who say, we had to change it. We had to make it fit. okay? All these are implementers. And then we asked them questions about the agency, and we asked them questions about their perceptions of what their funders are telling them. So when you look at these, there was no differences between the adapters and the high-fidelity agencies in whether or not they were funded directly by the CDC, whether they received Ryan White funding. Questions like, I believe it is important to implement DEBI programs exactly as implemented by the original researchers. The state health department tells agencies to implement DEBI programs exactly as the original researchers implemented. The CDC tells agencies to implement DEBIs exactly as the original researchers. You notice that these agencies are saying that they're being told that, but not differently, right? The perceptions don't differ from the high fidelity and the adapters, okay? So it isn't like the high fidelity guys are saying, yeah, we're doing it because they told us to do it this way, any more than the adapters believe that. Right? No differences. On agencies should remove activities from a DEBI program. Low fidelity, the adapters aren't saying that more than the high fidelity. They're all saying it a lot, right? But the one of these questions that differentiates the fidelity and the adapting interventions is this statement. Our agency has difficulty finding evidence-based programs like DEBIs that fit our community, right? The high fidelities, right, are less likely to say that than the adapters. And so that's what's going on with the DEBI. If people are changing it for community fit. Beautiful case study at Harlem United. And by the way, I was at the Healthy Relationships training when the Harlem United guys were there getting trained. Oh, really? And they were good, yeah. So the conclusions are, 78% of agencies trained in healthy relationships actually implemented. That's good to know. The most common reason for not implementing was lack of community fit. More than half of those who implemented made adaptive changes, most often to improve community fit. And behavioral interventions must fit the community needs, or they're not going to be used, or they're going to be used differently than intended. And if you think about technical assistance and where the CDC should really be putting their effort in helping agencies, it's in that area that I know you're doing a lot of work in, which is helping the intervention fit the community. And I have to say, just as sort of an outsider, for a long time, I've seen CDC really change their tune on this. You guys were much more high fidelity in the beginning, and much more helping to adapt now. And I think that's I think, for whatever that's worth, I think that's a good thing.